Thank you very much, Eduardo, for inviting me. It's always a pleasure to speak to people from Brazil. I have a lot of respect for the doctors from your country, and many of them are now training again with me. And over the years, many have received their training here. So it's always a pleasure also to speak to students because they are our future. I will try to cover elements of the prediction and prevention of preterm birth. Preterm birth is important because it is the most common cause of death and handicap in obstetrics, and over the world, there are 15 million preterm births every year, and more than 1 million deaths in neonates as a result of prematurity. And this graph shows the countries that have a very high incidence. Africa, always because of poverty and infections. Southeast Asia, also poverty. Very strange that the incidence is very high in the United States because it's a very rich country. But the problem there is that there is inadequate medical care for a big proportion of the high risk of the population. Brazil is not too bad. The risk is overall in the intermediate group, actually in the low risk group overall, Brazil. So you're doing well already. Let me first of all deal with singleton pregnancies and then twins. In singleton pregnancies, premature birth is defined as birth before 37 weeks, but in reality, in most countries of the world now, a baby that is born at 36 weeks will survive and will be all right. The big problem is birth before 32, 33 weeks. And if I look at the incidence of that, it's only about 1.7%. So that is the main cause of death. Birth before 34 weeks, let's say. We can then divide premature birth into two groups. Those that occur spontaneously and those where the doctors cause the premature birth because the baby is not growing well, fetal growth restriction, or there is placental insufficiency, or there is preeclampsia, or some other medical condition that requires the early delivery. And more or less, 40% of the premature births are iatrogenic, medically driven, and about 60% are spontaneous. So here we are. If we look at 60% of the 1.7%, then the incidence of birth for 34 weeks is about 1%. In terms of the iatrogenic preterm birth, I think we have made a big progress because now we can predict in the first trimester of pregnancy by a combination of maternal risk factors, uterine artery Doppler at 12 weeks, the measurement of blood pressure, and the measurement of placental growth factor, the high risk group of delivering before 32 weeks because of placental insufficiency. We can identify at 12 weeks about 90% of the women that will have early preterm birth. And we can treat this group from the first trimester with aspirin, 150 milligrams every day from 12 to 36 weeks, and we can reduce the rate of the most severe type of prematurity by nearly 90%. So that is the iatrogenic group: preeclampsia, growth restriction, abruption, early prediction and prevention with aspirin. What about the prevention of spontaneous preterm birth now? Many people have tried many different things. They have tried bed rest. It doesn't help. They have tried various vitamins and supplements, iron, folic acid, calcium, zinc, magnesium, and fish oil. increased visits to the antenatal clinic, psychological support, staying at home and not working, and none of these measures have been found to be beneficial in the reduction of preterm birth. Now, a few years ago, there was some suggestion that the supplementation of the diet by various omega-3 supplementation can reduce the rate of preterm birth. And people were very excited about that from a meta-analysis of various studies in which omega-3 was given mainly for the prevention of preeclampsia. But a big study in Australia has shown that, and this is a very big study, where women were divided into two groups, and one group received omega-3 and the other placebo from 20 to 34 weeks, and there was no reduction in the rate of preterm birth, either total or spontaneous preterm birth. So that was the last story of a hope that something in the diet can improve and prevent preterm birth. The one thing that could potentially prevent preterm birth is injections of 17-hydroxyprogesterone. And one study in the United States showed that in the group that received this 17-hydroxyprogesterone, there was a major reduction in the rate of preterm birth by comparison with placebo. And therefore, they got very excited in the United States, and they recommended one company to this Lumara company to market this 17-hydroxyprogesterone. What was extraordinary is that as soon as the company received this supplementation, then immediately the company increased the cost from $200 to $11,000 for each patient. And that was extraordinary. So that is what happened with the story of 17-hydroxyprogesterone. And then another trial was carried out, and the results showed that injections of 17-hydroxyprogesterone do not reduce the rate of preterm birth. So this is for women that had a previous preterm birth. So previous preterm birth, 17-hydroxyprogesterone was very popular, but more recent evidence shows that this is not beneficial in preventing preterm birth. The best way to predict women that would be at high risk of preterm birth is to measure the cervical length during a routine ultrasound examination at 20 weeks. In women that had a previous history of preterm birth, or they had LETs, then laser conization. In these women, we can start measuring the cervical length from 16 weeks. And if the cervix gets short, these women are at increased risk of premature birth. And the black histogram is the normal distribution of cervical length, and the red one is in the women that had a preterm birth, the length of the cervix is shorter. And we developed models where we combine maternal history with the measurement of cervical length at 20 weeks to predict a very high group at risk, especially those that deliver before 28 weeks. So this method of screening is very useful in the prediction of a high-risk group for very preterm birth. And then the question is, what can we do? And at that time, this is now nearly 20 years ago, we did a screening study involving 47,000 women. We identified the high-risk group with a very, very short cervix of less than 15 millimeters. And then we did a randomization of expectant management against cerclage and unfortunately that was not beneficial. However, in a subgroup of women where the cervix was short and the women had a previous history of preterm birth, in that group, then the rate of preterm birth was reduced by about 30%. So cervical cerclage is useful if you have a short cervix and a previous history of preterm birth. And then we had this story of the cervical pessary. And this is a pessary that you put around the cervix, and it was very attractive. And the study in Spain by Goya showed that this was a fantastic test method because it dramatically reduced the rate of preterm birth from the controls, 27% to 6%. We did another study, and unfortunately, we found that there was no benefit at all. So the hope that this was useful was not confirmed. And then 2 years ago, Roberto Romero carried out a meta-analysis of all of the studies using the pessary for women with a short cervix, and they found that this did not reduce significantly the rate of preterm birth. The only thing that appears to be very beneficial is vaginal progesterone. And here you are, Eduardo Fonseca, the first one, when he was my fellow in London in 2007, he published this very important paper in the New England Journal of Medicine, where they showed in this paper that if you take women with a very short cervix, less than 25 millimeters, and then you give them vaginal progesterone, then you can substantially reduce the rate of preterm birth by about 40%. And we had other studies that have confirmed this original observation. And now, overall, we can tell women that have a short cervix at 20 weeks, vaginal progesterone, 200 milligrams every night, can reduce the rate of preterm birth by about 40%. So this is the summary of singleton pregnancies: first trimester screening for preeclampsia and prevention with aspirin, and second trimester measurement of cervical length. And if the cervix is less than 25, treat them with progesterone. If the cervix is less than 25 millimeters, plus a history of previous preterm birth, treat them with cervical cerclage. What about now twins? Twin pregnancies are found in less than 2% of all pregnancies, and yet in twin pregnancies, the rate of preterm birth is very high. In singleton pregnancies, I showed that the preterm birth rate before 34 weeks is about 1.7%, whereas in dichorionic twins is 10 times higher, 15%, and in monochorionic twins is 15 times higher at 28%. So much so that twin pregnancies that are responsible for less than 2% of pregnancies are also responsible for about 20% of preterm birth. So twins are bad news in terms of preterm birth. Bed rest does not help. Cervical cerclage has been found not to be beneficial in women with a short cervix and twins. If anything, in these women, the risk is increased. And the question then was the pessary again. There were 2 studies of routine screening of all twins and the use of pessary, and this has shown no benefit from the use of pessary. There were other studies that have shown that if the cervix is short and you put a pessary in twin pregnancies, you can reduce the rate of preterm birth. But this study, again from Spain, there are many other studies that have shown that in twins with a short cervix, the pessary is not beneficial. Question then is, this is a meta-analysis which looks at the pessary, and it shows that it is not useful in twin pregnancies, either for spontaneous preterm birth for 34 weeks or a composite of adverse neonatal outcome. And this is true for both unselected twins and those with a short cervix. So the pessary is not found to be significantly improving, reducing the rate of preterm birth. What about progesterone? We heard that progesterone is useful in singleton pregnancies with a short cervix. Is it useful in twins? There are many studies that looked at progesterone in unselected twin pregnancies, and unfortunately, there was no benefit at all. The question then that I tried to address is, can we use progesterone from the first trimester? Because all of the previous studies were usually in the second trimester. And maybe I thought leaving it for the second trimester is not useful because these women may go into a process of premature birth which cannot be reversed. So let's start from the first trimester. So we carried out this big study of more than 1,000 twin pregnancies that we randomized into progesterone, and we gave them a high dose of progesterone, 600 milligrams every day from 12 weeks. And we found that there was no benefit. The progesterone is the red, the blue is the placebo. This is the cumulative rate of spontaneous birth, and there was no benefit at all, except in a very small subgroup of women that at 12 weeks had a shortish cervix. In the women with a cervix of less than 30 millimeters, you can see that progesterone was reducing the rate of preterm birth. In the group with a longer cervix, there was no benefit from progesterone. So what have we learned? We have learned that in singleton pregnancies, we have to distinguish between spontaneous and iatrogenic preterm birth. We can reduce the risk of severe preterm birth due to preeclampsia and fetal growth restriction by screening in the first trimester by blood pressure, Doppler, and placental growth factor, and treating the high-risk group with aspirin. In terms of the spontaneous, it seems that the only definite benefit is in women with a short cervix receiving progesterone, and Eduardo Fonseca is responsible for this revolutionary discovery. In terms of twin pregnancies, they are responsible for a very high proportion of preterm birth, and here nothing seems to be beneficial except perhaps high doses of progesterone starting from 12 weeks in a small subgroup of women with a short cervix. So thank you very much for giving me this opportunity to give you a quick summary of preterm birth in singletons and twins.